Thank you very much, Chairman. So I'm really inspired by all the things we see here, and I feel some quietness in the room, but actually what we are seeing here is actually amazing, right? Patients running over the ward, diminishing or full resolution of liver tumors. And so, yeah, it really gives me a lot of energy. And now I'm here to talk about prostate cancer and also a little bit about benign hyperplasia of the prostate. You don't do this alone, you do this in a team, and the red technologists are very important in this because actually they do most of the work. We'll talk a little bit about prostate cancer and the treatment. I will talk about enforced focal trial. I'll talk about prostate HIFU and the TULSA treatment. I'll show you some treatment cases. I will talk about follow-up after ablation by MRI. We'll go over some screening cases together, and we'll talk a little bit about benign prostate hyperplasia. So, prostate cancer, most common malignancy among men. 2 out of 7 patients have metastasis at diagnosis. 5-year survival, 90%, 10-year survival, 80%. Most people die with prostate cancer, not due to prostate cancer. Okay, so there are different grades. I like to keep things simple. It's for my brain, otherwise it will not fit in. We have low risk, intermediate risk, and high risk. If you're low risk, no active treatment, we could do surveillance. If you're intermediate risk, Gleason 7, you can do follow-up of patients, which is being done quite often at this often older population, but you could also do active treatment, and this is where we will talk about later in this talk. If you have high-risk patients over Gleason 7, you go for active treatment because you get significant better oncological endpoints with radical therapy. So we will talk about intermediate risk patients here, Gleason 7, and this is where focal therapy comes in. So why is focal therapy interesting? Both patients and physicians have a tendency to be interested in more alternative treatments, minimal invasive treatments, to look more at quality of life, instead of maybe only oncological effectiveness. But all the studies that have been done were mostly feasibility studies, pilot studies, cohort studies, and we need a randomized clinical trial to prove effectiveness of focal therapy. So we look here at Gleason 7, and we look at complication rate, quality of life, which can be defined by incontinence or impotence. We also look at potential reduction in complication-related costs, so not only the treatment, but also the lifetime problems. And of course, we have to look at reintervention after focal therapy. And one of the advantages that other therapies after focal therapy remain possible. So this is the TULSA Pro system which I'm working with in Isala Hospital. You have an MRI scanner, a normal table, you have an applicator, you have a transducer that is, you have to get a new one every time. It's a disposable one, and also a rectal cooling device, which is also used to clear the rectum from air. And of course, outside the MR intervention suite, you have a control room. It's almost like, I don't want to be disrespectful, but it is very fancy. It's very cool to actually be able to remotely treat a patient. So in the enforced trial, we look at cost effectiveness of focal therapy versus standard care in a randomized clinical trial, one-on-one randomized. We look at oncological effectiveness, quality of time, cost effectiveness with patient file questionnaires. We do clinical examinations, PSA values, MRIs and biopsies, and we do that in a quite rigorous follow-up scheme. And we do this in the different participating centers throughout the Netherlands, not just the Netherlands as a participating centers, but also different kinds of focal treatments. So it's not only HIFU by means of TULSA, but also HIFU by the focal one, or IRA, irreversible electrical evaporation. So you need to be a man, of course. You need to be over 40, no concomitant cancers. The prostate shouldn't be too big. Prostate specific antigen levels in serum shouldn't be too high. Gleason 7, and it has to be unilateral because we're looking at focal therapy here and not at whole gland ablation, which of course is also a possibility. So there are some contraindications here. If you have a pacemaker that's not compatible or not general anesthesia, if you have calcifications or cysts that interfere the ultrasound beam, it's not preferable. I will show you some cases. And if you have previous active therapy for prostate cancer, you're also excluded. So there are two differences. There's a difference between the TULSA-PRO and the HIFU Focal One. The Focal One comes from the rectum and is good for ablation at the posterior side. It has less problems with heat sink, and the TULSA-PRO is totally non-invasive through the urethra and can treat the whole gland also in the front, in the ventral side, which the Focal One is not able to do. So you see a schematic design of what happens. You introduce the catheter with the different elements, and up to 1 millimeter you can ablate the tissue and keep the urethra intact as it is actively cooled over there. Anyway, so we can draw manually the regions of interest, but there are also now AI applications coming in that automatically delineate and make the work even more easier for you. So this is the TULSA system. I don't know if everybody knows how it works. So I make you a small animation film. You can find it also on the internet. So the male is positioned in the MR, the transducer is introduced, elements are being placed at the right position, screening images are made, so in order to be able to draw the region of interest, and then the computer does the rest. So the treatment time is very short relatively. The most of the time is being used to get the patient into the MR suite, give him general anesthesia, etc., etc. Repositioning. That takes a lot of time. So that's why the radiology technicians are so important and so crucial in treating these patients. So you actually can see here that a total lethal thermal dose is being administered throughout the whole gland in less than 30 minutes. I think it's quite impressive. Right. So preparation, seeing, planning, temperature controlled, and finally a confirmation by administrating intravenous gadolinium to look for a non-perfused volume here. So it's an example of a case over time. On the left you see the screening T2 MRI with lesion over here. You ablate the whole prostate, there's no residual viable tissue left. And 1 month, 3 months, and 12 months you see a 92% decrease of prostate volume. So, how does TULSA relate to other treatments? It's it's on par or even better if you look at complication rate and quality of life. Here you have an example of treated resect study that only focal lesion was treated with HIFU. So this is a case from with courtesy of Dr. Jürgen Futter in Radboud Nijmegen University, which we work very closely related to. So you see here a very low T2 lesion, high on the B1000, and a focal treatment here. So you can see actually live all the elements being controlled. You can actually adjust them, give them a boost if you want it extra. You can go back and do an extra sweep or go the other way around. So we often start a little bit in advance of the lesion in order to get the energy build up as we want it. And if you see below here, after contrast, there's no residual tissue left anymore. So it's important to talk about follow-up of these patients because it's a nice intervention, but nothing is 100%, right? So we have to monitor these patients, and not only by PSA, because it's highly unreliable, actually. So you have to do multi-parametric MRI with gadolinium every year till 5 years post-treatment. You have to do questionnaires, quality of life, long-term follow-up is important because the urological community really cares about prostate cancer mortality as an outcome measure. So another case is from our hospital in Isala, 74 years, PSA 3.7, Gleason 7. You see here actually on the right, low T2, high on the B2000 and low on the ADC. And here we treated the patient with adequate hemiablation total lethal terminal dose was achieved, and you see here that there was actually complete resorption of the prostate tissue on the right. So in this patient still has the capacity of a functioning prostate, which is good for quality of life. So we need to check on these patients, and there are many image-guided ablation techniques. You have HIFU, you have TULSA, you have laser ablation, cryoablation, phototherapy, irreversible electroporation, focal radiotherapy, RFA, MVA, PA. So many things out there, all competing technologies. Everybody wants a piece of the pie. But how do we really assess these patients after they've been treated? So there is a new classification system, the PIFAB. It's quite easy actually. It's good for my mind. Only 3 categories here: PIFAB 1, 2, and 3, and it's based on the enhancement curves on the delayed enhancement or the enhancement images. You look at the B values and the ADCs, and if there's no enhancement, if there's no high B2000 signal, if there's no low ADC, and there's no abnormality on T2, okay, you can continue monitoring, easy cases. Right? If there's enhancement, a high B2000 and a low ADC, okay, that's also easy, right? You have to go, you fall in the category number 3, and you have to do a biopsy. But the difficult group is, of course, the group in between. It has some enhancement. It doesn't really definitely show high B2000. It's maybe show a little bit low T2 and low ADC. And then you have to correlate with PSA kinetics over time. And you could do a follow-up MRI, or you could do a biopsy in close collaboration with your patient. So this is a case where there's an apical lesion in the right peripheral zone before treatment. And after treatment, we see here little C-shaped enhancement, which was really fast in the beginning. You have to really look at the curve, early enhancement. You see a high B value, low ADC, and low T2. So this was a recurrence, and it needed to be treated again. So this is an important observation, because I go over this very quickly. You get all this research of 10 years in 15 minutes. But it emphasizes why it's so important to centralize this treatment and do a lot of cases. So this is a screening case I would like to go over with you. Axial T2, low T2 lesion, high on the B2000 and low on the ADC. Is this patient eligible or not? Hands up, eligible? Non-eligible? Right, it's eligible. 10 points for Dr. Fazi. Huh? All right, screening case number 2. Axial T2, it's a lesion of 22 millimeters, absolutely high T2, low ADCs and high B2000. Is this case eligible or not? Hands up. Is it eligible? Yeah, Dr. Fazi is doubting. He's right. It's not eligible because it's more than 1.5 centimeter, and we know from treat and resect studies, if the tumor is more than 1.5 centimeter, you have more chance on capture breach, right? And but this is also 1.5 centimeters. It's not exactly 1.5. It depends on many things, like is the prostate not too big, etc. Okay, screening case number 3, people. Is this patient eligible for TULSA? We have a lesion at the ventral side here, low T2, high B2000, low ADCs. Can we say if it's eligible or not? No, because there might be calcifications. So the referring radiologist often has an ultrasound available that can already predict whether calcification or not. You often have a PMSA scan that you have an attenuation CT. You can take a look, and sometimes you make an extra CT, or you could also look at susceptibility imaging in the MR. We are doing some research about that as well. So this patient is not eligible because the calcifications are in front or next to the lesion, and we will not be able to have a good thermal lethal dose over there. So screening case number 4, yes or no, eligible, axial T2 low, high B2000, low ADCs. Yes or no? Maybe, Dr. Frost, yeah. There are calcifications, but they're on the back side, the posterior side. They're not intervening the beam from the urethra, so you can actively treat this patient. Right. So, I would talk a little bit more about TULSA. I have, give me a few minutes, please, and then I'll wrap up. You can go for full prostate ablation in prostate cancer or in benign prostatic hyperplasia. You can go for focal treatment in prostate cancer, but you also go for partial treatment in benign prostate hyperplasia. But a unique thing, you could also do salvage therapy after local recurrence of prostate cancer, for example, radical prostatectomy. So, we don't have RCTs on benign prostate hyperplasia, but the first results from cohorts are very positive, right? So we get a 92% prostate volume shrinkage if you treat the whole patient, and the prostate severity score is absolutely amazing, right? So if I look at these graphs, you get a peak flow rate, you're back in business. You have less post-void residual, quality of life is better. So this is actually just really great treatment. And is it on par with all the other ones? TURP, laser, urethral lift, water vapor, arterial embolization, water jet? Absolutely, it's on par, even better. So this is very promising for the future. But time is money in the MR intervention suite. So I am very happy with the new development that with AI you can actually delineate very fast and go for a smaller plan. So as we all know, the formula for volume 4/3 PR to the third power. So the last few millimeters is the largest volume of prostate. So if you can only do a little bit, it might already be enough. And then you actually have a ablation of 3 cc's in 60 minutes. Which is very impressive. Is everything gold on the future? Yeah, it's not for free. Catheters, transducers, they are not very cheap. They're quite expensive actually. So if you don't centralize this, if you don't get into a good volume setting, I don't think this will fly. So I think, okay, take home messages, people. Patient selection always is key. This is somewhere the urologist has a major, the magic happens in the consultation room of the urologist. If your urologist is not on board on this, forget it. Screening, we had a talk from Martin earlier today. It's easier said than done, people. Screening in prostate cancer, you will get a lot of work. But if you go for screening, and we have learned today that you do it by MRI, you only do biopsies on the MRI. You do the treatment with MR HIFU, but you also do the follow-up with MRI. So we actually are talking about, the question is, are we going for an MRI approach in the whole cycle of this patient or not? I think expectation management is very undervalued. If your referring physicians do not know what they can expect, then they will not refer. And it's for patients as well. What do we really expect in this phase of life? A 40-year-old or a 60-year-old, an 80-year-old, is very different. And I think we really have to go for quality of life here in this patient category, and not only for curation with oncological measurements, but that's a level 4 opinion. Minimal to non-invasive seems non-inferior, but remains to be proven by high-quality RCTs. I think we need this kind of evidence. And when in Egypt, where 120 million people are living, and only in Korea are 21 million, if you're going to do treatments with HIFU, it's a great opportunity to do RCTs that are needed, and will bring the further community further, and will put Egypt in its first position. BPA, also very good with other interventions, but also here we need an RCT to do cost effectiveness, etc., etc. And I said it before, my message to Egypt is centralized treatment, create volume, get experience and quality, and you really need research. And last but not all, if you want to let this fly, become close friends with your anesthesiologists. Because everywhere I go, the limitation is not the machine, it's not the radiologist, but is there anesthesiology available? Thank you very much.